All right. So this will be the second installment of our little seminar chats. And again, we'll talk today, and then any questions that might have, any Q&A that you want to bring in from any of the articles or from the topic we're going to discuss today, you can bring in at the last 10, 15, 20 minutes of class on Tuesday. So I'm going to try to keep this brief because I know the last one went over a bit. And I actually have a PowerPoint for this one today. And I just kind of want to share the screen with you here really quickly and see if I can't pull this up. All right, so this would be easier. All right, there we go. So I'm going to take you through a slideshow, and this is actually a presentation that I gave with a couple of colleagues at Bellevue Hospital. What I want to talk about today is how we take a theory and adapt it to fit a population when we're talking about group dynamics. So this was a presentation we called Exploring Connection, Innovative CBT Group Programming at CDOP. CDOP is the Chemical Dependency Outpatient Department at Bellevue Hospital. I co-created this group with David Knos, who's a psychologist, and our psychology intern, Emily Maynard, at that time. So first I want to talk to you a little bit about why we had to adapt the model. CBT is really great. It's very easy to research, and that's why there's so much great research out there about it. But usually for research, you have to have kind of a clean sample. And our folks at Bellevue, because Bellevue is a city hospital, so it treats people regardless of their ability to pay. So a clinic, a chemical dependency outpatient clinic like ours, there's a lot of them all over the state, but ours was unique because the population was incredibly complex. But even just beginning with this idea of substance use, I just give you a little bit of a stat to kind of bring home where substance use was at in our country at that particular time. So it was 2012, and that was even 2 years old. So I think it was about 2014 that we did this project. At the time, SAMHSA had done an estimated survey of 23 plus million people would need treatment for substance use problems. Of those individuals, of that 23 million, only 2.5 or 10.8 were actually receiving substance use treatment. So a little bit about our clinic. We're licensed by OASIS, which is in New York State is the Office of Alcohol and Substance Abuse Services. And they cover and sanction and fund all of the substance use treatment and prevention programs in the state. Our admission criteria was there. You had to be 18 or older, had to have a substance use diagnosis. There had to be like a reason that you needed the treatment, but that didn't need more intensive treatment like inpatient rehab. And you just had to be considered safe, meaning no active suicidal ideation or homicidal ideation. So this is sort of where I think it'll bring it home to you on why we needed to adapt the model. So co-occurring psychiatric disorders for clinics like ours in the state is the green bar. So co-occurring psychiatric disorders in most chemical dependency outpatient departments hovers just under 40%. Our co-occurring rate was almost 85%. Coexisting major medical issues, you can see that as well. The state average was below 20%. Ours was up near 80%. And then for homeless population in New York State, for a clinic like ours, hovered around 14%. Ours was right at the edge of 70%. So you can see that our population was already much more complex than the state average. But when looking at CDOP, or I'm sorry, at CBT and its use in group dynamics, the populations that they were tested on were even more focused than even the New York State averages. So just in regards to our hospital, during the time, and this is one of the reasons why we decided that we really needed to introduce more cognitive behavioral therapy and more evidence-based models, is that between 2012 and 2013, we saw a skyrocket in the referrals that were coming to our program from our inpatient mental health units. So you can just sort of see how in 1 year it went from an average of 10 all the way up to 17, and that's on a monthly basis. So we had to respond, right? So as a clinic, we wanted to build on what was working. We wanted to place more of an evidence-based focus. We had a new unit chief, and we had a new psychologist that really wanted to bring a new level of energy into the work. We already had a variety of groups like art therapy. We had our sobriety garden, afternoon groups, peer-led groups, but we wanted to add something that really had a little bit of oomph in regards to evidence-based. We started to do monthly in-service trainings where myself, the psychologist, and a few other specialists would do trainings. And what we did, we increased our CBT groups, which is what this presentation is about. We introduced trauma-informed work, and we started really enforcing the idea of motivational interviewing and stages of change into all the work that we did. So a little bit of history behind the CBT group. The group itself had been run for a while, and it was usually completely run once a week by the psychology intern. And it usually followed a very traditional CBT approach. It wasn't focused for population. It wasn't focused for diagnosis. It was just very focused on the ABC model, and people would bring the issues of their life in, and they would process it. When I came in as a graduate intern, the group was turned over to me, and we started to incorporate more of a systems model to the CBT program, and we started to really focus in on the diagnoses of dual disorder, what those symptoms were like, and people really started to respond. It became a very, very popular group. We ran that way the entire time I was an intern, and then when I came back as a full-time employee, picked right back up with that. It was always a very popular group. If any of you remember Superstorm Sandy came in, and Bellevue Hospital had to be closed down for a bit, and they moved our clinic to Metropolitan Hospital. So at the time I was a temporary employee, so I got laid off, and our psychologist, Dr. Knos, took over and really loved it. He saw the culture and the community that we had created within the group, really responded well to it. So when Bellevue came back to Bellevue, he didn't want to give up the group, and neither did I. So we decided to talk about collaborating and bringing the two groups together. But we instantly knew that there would be some challenges specifically to our population. We both recognized that the way it was being done for our folks, it wasn't as powerful and effective as it could be. So really quick, around CBT, it's evidence-based for interventions with substance use and co-occurring disorder. The thinking is that because so much of the habit of substance use is based around relapse prevention, and relapse prevention often occurs within this sort of unconscious response in a lack of coping skills, and the CBT can end up creating a lot of coping mechanisms and a deeper understanding of what's happening. And the same is true with many of these mental health disorders. So here's just a real quick brief, a few citations that we use to sort of model this program. But you'll see how when it's talking about alcohol use and substance use disorders, major depressive disorders, oppositional defiant, or obsessive compulsive disorder, you're not seeing a lot of the dual disorder reviews because it's a more challenging study. So when we looked at our population, some of the challenges that we immediately identified was that we have a changing population. And that's not just for the clinic, but the group, our group itself, because all of the groups were open. They weren't closed groups. So we would have different people coming in at different stages of the group. So how do you end up, adapting the group to meet the needs of people who might not be there each time? Our changing population also was a result of that homelessness factor, as well as that major medical issue factor that you saw earlier on. People were transient and being moved around the city from shelter to shelter, and depending on the commute time, we could lose our population very quickly or gain a lot of people at the same time. The open group format worked against us a little bit. Our treatment was ongoing. CBT is usually very focused, time limited, but ours was a never-ending group. So how do we adapt this short-term model to long-term treatment? And there was an inability to do issue-focused or symptom-focused CBT due to the fact that all of our group members had such complex presentations. So what we decided to do, and this was through combing through the literature, through our own qualitative responses to the work that we had been doing, we found that what worked the best with our population was focusing on the psychoeducational aspect of CBT. And this was something that our clients ate up, talking to them about the brain, talking to them about the mind-body connection, psychoeducating them about current research on what addiction was and what it wasn't, and utilizing the psychoed part of CBT that really talks to people about how do you think, how does your thought become a belief, how does belief become habitual behavior. They really, really attach to that concept. We did a lot of group activities and role plays. Our group was set at 2 p.m., so they had already eaten. People were a little bit tired of being in treatment all day. And we also knew that we could use the evidence base, because a lot of our clients just loved it, to show how useful it was to a variety of issues. So if people brought in different experiences that they had, whether it be anger management, relapse prevention, we could show how the techniques and tools crossed over. And then the other piece was that we encourage the use of CBT in individual sessions, as well as referring folks to places that utilize CBT in a self-help paradigm. I don't know what just happened to this presentation, but let me see if I can get rid of it and get you back over there. I hope that you're seeing this. Anyway, I'll find out in a bit. Yeah, and so we had to talk to other clinicians about making sure that they were using CBT in the individual sessions. The next piece was also sort of a belief system that we had to run up against, and that was this idea of parallel versus sequential versus integrative treatment. So parallel treatment, it was an innovation in substance use treatment. It used to be first you get someone sober and then you would send them to substance use or mental health treatment. Eventually they started to say, all right, we can try to treat them at the same time. We'll treat your substance use over here and we'll refer you out. Sequential meant either you dealt with the mental health or the substance use first. Integrative, which every bit of evidence that we see shows works the best, is to really talk about both issues at the same time and talk about how they're interconnected and related. So that brought up the next question was, if we're doing integrative treatment, do you have to insist upon a period of time for sobriety as a form, as an entrance point for therapy? And this, might seem like a no-brainer to social workers, but in other areas, it's a very contentious conversation. A lot of clients will go in seeking mental health treatment, mention that they're using drugs, and they're immediately referred to a substance use treatment center that they have no interest in going to. So we had to work with the model of our own clinic to allow for more of a harm reduction model as we walked in to this process. So here are so we came up with a revolving curriculum, which would take place over the course of a couple of months. Oops, what's happening here? I think I'm trying to just make sure that you're seeing what I'm seeing. I hope that you're seeing what I'm seeing. If not, I'm going to have to do this whole thing again. Well, okay, so we came up with this revolving curriculum that we really felt was really good. It would be, we decided that we were going to take the group itself and expand it from 1 day a week to 4 days a week, feeling that this would capture more of our transient population and allow more people to experience it. So we decided to take the ABC model, the thoughts, feelings, behaviors model of CBT, and break it into 3 groups with a 1 wrap-up group at the end of the week. So on Tuesdays, they had thoughts group. On Wednesdays, they had feelings group. On Thursdays, they had behaviors group. And on Fridays, they had a wrap-up group. And the goal was to have all of these 3 concepts link, and then the final group would be taking all of the lessons of that week and doing it in more of a traditional CBT group method. The beauty of that was that I ran the wrap-up group, and I could get the feedback from each of the other group leaders by the end of the week so that I could put together a wrap-up group that really incorporated not just the concepts, but also the content of what had been talked about during the week. So we did the feelings group. The purpose of emotions was one of our topics. And this was fun for them because we talked a lot about the science, the evolution, the function and purpose of feelings. We talked about recognizing and naming emotions and how difficult that could be. There were some games where they would do facial charades and people would have to guess what mood they were feeling or trying to express. It was a lot of trying to build emotional intelligence within the community so that people could not just recognize what they were feeling, but also recognize what other people were feeling, and then try to tailor their behavior to that reaction. We talked a lot about the 6 universal emotions. That was an entire group. And then talked about the variance of those feelings. And so we use this massive feelings wheel. And folks would constantly, you would start in the middle, and you would try to compartmentalize your feelings. So you might start with fear. Someone would say, what were you feeling in that moment? Fear. All right, let's break it down to the wheel. So were you feeling humiliated, rejected, submissive, insecure, anxious, scared, startled, confused, amazed? And if they identified one of those, then you would say into, all right, so it was humiliated. Was it because you were being ridiculed, disrespected, alienated, inadequate, insignificant, or worthless? And so we would have entire conversations around those things. And the bigger question was like, well, how can you tell which is different? How can you tell what fear is based on humiliation versus anxiety, which fear is more about being overwhelmed or inferior? And what you were really trying to do is help people sort of catch the wave before it dominated them, recognizing the signs of fear and sort of the language of the emotions behind it. This was an incredibly effective way for folks to do that. We would talk about judgments and myths about emotions, things like other people are the best judge of how I'm feeling. And there's a right way to feel in every situation. Those 2 quotes come from Linehan's use of CBT in treatment of borderline personality disorder. So you can see how we were also bringing in concepts of DBT, which is a cognitive model with the mindfulness aspect added to it. But we talked a lot about like the myths, like where do our belief systems come from? How have previous experiences led to this? So again, this is a slight departure from short-term models, because we knew that we had to bring in the larger schema therapy aspects of treatment, of CBT treatment, so that we could meet our clients with where they were at, because there's a lot of self-reflection in substance use treatment, and we knew that they were doing that. So we wanted to incorporate something that would help them catch origins of belief and origins of patterns, so they could start to challenge some of those things for themselves. Our thoughts and behaviors group, here's just some examples of things that we did there. We talked about thinking about feelings and what does that mean to partialize that experience, because so many times for folks who are living in habitual patterns, especially substance use, because it trains away delay of gratification, because the drug works so quickly, that people have difficulty delaying immediate gratification response feelings. So we started trying to help people break those things down, asking themselves questions. When they would come in having had an event during the week, we would say, are you responding to thoughts or are you responding to reality? And really making a distinction between those 2 things. And that language is a little harsh, but it would usually be, is this based in what's actually happening, or is this based in history? Here and now or back and then, right? So we would look to a lot of cognitive distortion language, like helping people recognize what their thinking patterns were and sort of name them so that they could have some autonomy and agency over that. So things like jumping to conclusions, personalizing, catastrophizing, labeling, black and white thinking. Once we found that they were able to sort of identify those things for themselves, we noticed that they started to be able to identify it in each other as well. This is where we started to really see the universality and mutual aid of the group really coming into play, where people were able to say, Steve, it sounds like you're jumping to conclusions there. It sounds like you're catastrophizing. Maybe we should break that down on the feelings wheel. So that was the language that we were starting to hear from the folks that we were working with. So we knew it was starting to really kick in. We taught them the ABC model so that they could break down their own behavior on a daily basis. There's a wonderful step in Alcoholics Anonymous, the 10th step, which is on a daily basis, they take an inventory at the end of their evening about different ways that they behave, to see if they need to make an amends or if they need to forgive a resentment. And this ABC model worked into that. We would ask them to do that at the end of the day as part of their 10th step, to kind of look back and examine moments in the day and put it on the ABC model. And they responded really well to that. They loved the concept of the behavior-mood connection, because it allowed them to target the problem outside of themselves. Recognizing that what was happening was a reaction to an environmental trigger gave them a little bit more autonomy and made them almost want to fight back against the the habitual pattern. We introduced the concept of coping, trying to trade out the maladaptive stuff for the more adaptive stuff, helping them recognize where their thought patterns and beliefs were actually keeping them from the life they want. This is an MI concept of, exploring the difference between behavior or value and action. And then we talked a lot about the idea of active and passive behavior in regards to avoidant tendencies and avoidant technologies that sometimes slip in when we're talking about substance use and mental health issues. One of the biggest things that CBT does that's really great is partialization, breaking big things into small things, really helping people plan step-by-step things. Coping, worrying with rumination. We talked a lot about avoidant behavior. We talked about the George Costanza rule, the opposite to emotion action. If you're feeling like taking aggressive action, take more passive, try that out, see what the results are, come back and report. And then we did a lot of reconnecting with other people within the community. We had a lot of conflict that would erupt because we would come in and lay out a deep question, and then there would be a discussion and sometimes a debate about it. And that was great for us because it allowed us to use the tools of CBT and universality and mutual aid to help people resolve conflict. And then we started to hear them reporting using those same tools out in conflict in the world. And that's how we knew it was starting to kick in. We spent a lot of time on behavioral change. This actually is more of a DBT process, but it sort of looks at a step-by-step. This was Dr. Canos's idea, where he had set a goal to lose some weight. He would go to the grocery store, put fruit in the cart, walk over to the bakery, see the pie, choose a pie, put it in the cart, put the pie back on the table, put the pie back in the cart, buy the pie, bring the pie home, put it on the counter, walk past the pie again, friends call, have an argument, look at the pie, eat one slice, then eat the entire pie. So what we wanted people to recognize is that things aren't just happening out of nowhere, that there's a series of events that creates a level of vulnerability, and that if you can catch the vulnerability early and utilize some type of intervention tool early on, you can keep yourself from getting to the consequence that you don't want. And this was really effective, and we started to see them connecting with each other and doing these things more and more. We did a lot of assertiveness training, teaching people with the I messages, like when you do this, I feel this, helping people practice to say no. We did a lot of those role plays. Helping people make requests. We would role play going to HRA and asking for additional assistance. We would role play talking to their psychiatrist about med changes, all of those different things. It was very engaging. We used to do a thing called tag out. We would put people in scenarios, and if they couldn't solve it or they started to get frustrated, they could tag in somebody else who had a new tool or new technique, and they would jump in and try to solve it as well. We could take a time out, and the group would brainstorm different techniques and different approaches, and then they jump back in and try to finish it off. It was incredibly wonderful and incredibly effective at helping people learn how to problem solve. So then it came topics to the wrap-up group. It was very similar to the format that I was running before Sandy, before the Superstorm Sandy. It allowed them to bring in the topics from the previous groups, and they would teach the material to each other. Because I always started off with, all right, who went to the feelings group? Can you tell me about what was covered in there? What was your take on it? What were you thinking? And then I could fill in any of the gaps that they left out for the newer people, so everybody was on the same page. And then we would go, all right, who was at the thoughts group, who was at the behaviors group, and then we would bring it in. And so we sometimes would replay some of the activities that we had done. Mostly we were processing the effectiveness of it. And a lot of times, I would always say, has anyone had a CBT moment, which was a time outside of treatment that they had used some of our tools, or they wished that they had used some of the tools. And then we would go through in the moment CBT processing. If anything was coming up in the room, this was the group where I would really push it into the space, make a demand for work, and then we would use the CBT model in real time. So again, the wrap-up group, we focused on psychoed. I answered any questions that had come up about the other groups that maybe they had missed or something had been confusing, and it built on the integration of the model. So it was all about selling, and the other piece was selling it to clients who hadn't gone to any of the other ones, to talk about the value and the importance of it. And so the results, as a result of the group, we noticed in the members who were consistent, because we were able to track it, we did some evaluation measures. We noticed an increase in the length of time between relapses for those particular clients. We started to notice cognitive changes within the way that they related to one another, a lot of self-report coming back of using the tool. And one of the really big things that we saw was that the language of CBT started to become more and more of the language of the agency itself. We never really got the opportunity to take it in the future direction that we wanted, but we actually did want to publish the findings that we had and manualize the treatment. Unfortunately, Dr. Canos moved along, and eventually I did as well. Plus, they added a cooking group at the same time, and our population for the groups diminished greatly. People would rather eat than think. But the other big thing was that CBT did become more and more of a useful tool for the agency itself. And it really, I think, introduced to some of the counselors who had their reservations about evidence-based practice, it showed them the value of using some of those with our population. So this was sort of a really quick, briefer than last time. I think I tried to stick to about the 20-minute time spot. I welcome questions about this, how you adapt a theory to a population. During the Q&A, if you want to talk a little bit about groups that you're working with and how would you modify this, how do you take that theory and apply it there? I'm sure it'll bring up a lot of the things that I didn't have the time to talk about today, and we can fill in those gaps there. Also, if you have any real specific questions about other topics, because we can't get to all the readings, obviously, especially in this format, but if there are things that you want me to cover during the remainder of the semester through these little chats that we're having, please let me know. I know that there was a lot on diversity today and intergroup dialogue, which hopefully we'll have some time in class to discuss. But those are incredibly important concepts as well. So if that's something that's important, please email me and let me know where you want this little conversation that we're having to go moving forward. All right, so I'm going to edit this, throw it up on YouTube, and we'll talk about it on Tuesday. All right, take care.